Good afternoon, everyone, and welcome. My name is Dr. Kendra Nixon. My pronouns are she and her, and I'm the director of the Resolve Network and the professor in the Faculty of Social Work at the University of Manitoba. On behalf of Resolve Manitoba, the Alliance of Canadian Research Centres on Gender-Based Violence, and members of our Family Law, Family Violence Project, I would like to welcome everyone to today's webinar entitled Substance Use Coercion and Intimate Partner Survivors in Family Court. Next slide, Patricia. Before we begin today, I would like to recognize the land we are meeting on. Even though we are meeting remotely today and we are scattered across the prairies, even across the countries, it is important that we acknowledge the land we are on. I personally am at my office at the Fort Garry campus at the University of Manitoba, Winnipeg, which is located on Treaty 1 territory. Recognizing that I'm a visitor on the land and that Indigenous peoples have inherent rights because they are First Peoples is an important step in reconciliation. So in doing so, I would like to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Next slide. So I'd like to welcome everyone to today's webinar. The webinar is part of our Family Violence, Family Law project. The purpose of this study is to initiate, host, and support a community of practice comprised of experts, family law practitioners, domestic violence serving organizations, and intimate partner violence survivors or those with lived experience. So we're bringing people together to enhance ultimately the capacity of practitioners to address family violence safely and effectively. Through our community of practice, we hope to enhance support to survivors of violence through the family law system by increasing opportunities for family law practitioners to have training, guidance, and resources to support their work. And hosting regular webinars such as these is one way that we're doing that. I'll just want to say that we received funding from the Public Health Agency of Canada. The study is with the National or the Canadian Alliance of Gender-Based Violence Research Centres across Canada. The head or the lead center is at Western University with principal investigators, Dr. Peter Jaffe and Dr. Katrina Scott. Next slide. But of course, I want to acknowledge our three presenters today, and also someone with lived experience who I am going to read her account for her. So we have Dr. Carol Warshaw coming from Chicago today, Brina Murray, who's coming from Brandon, and Colleen Allen, who's in Winnipeg. As well, again, I want to acknowledge our funder, Public Health Agency of Canada, the Resolve funder, which is the Prairie Action Foundation, Ashley for the work that she's been doing organizing the webinar and the project, Patricia Carasoni, who is our digital communication specialist and helped assist with the webinar, and Teddy, who is a member of the University of Manitoba audio-visual team. So thank you to everyone. Next slide. Before we begin the content, I just want to have a bit of we call it a trigger warning, just to let you know that there is some disturbing content into today's webinar, so please take care of yourself. We do have a list of family violence resources available in Canada and encourage you to access these if you need. Next. So just a few housekeeping items before we begin. The webinar will be recorded. It's actually being recorded now. We will have the webinar made available. It's recording available and will be on our website, both the Resolve website and the Alliance website. We'll talk more about that at the end. All participants will remain muted and have their video turned off during the entire webinar. We will have a question and answer session later, which I will moderate. So if you do have any questions, please go to the bottom of your screen and type in your question there. Next slide. So just a very quick overview. We have 3 presentations, and then I will present briefly on behalf of a survivor. Then we will have question and answer period, and then a few closing remarks, and we will end at 4:30. Next slide. So again, I just want to welcome our 3 speakers. I'm just delighted that all of them have agreed to participate in today's webinar. I'm not going to go through everybody's bio, but we do have them here available if people want more information. We have Dr. Carol Warshaw, again, coming from Chicago, who is the director of the National Center on Domestic Violence, Trauma, and Mental Health. Dr. Warshaw will be speaking about substance use coercion as a concept and what she has seen in the family court system in the US. And it's really the work that I read from Carol about the idea of substance use coercion. I've never heard it coined in that way. And so I'm delighted to hear more about that. As well, we have Brina Murray, who is a family law lawyer in Brandon, Manitoba, who works quite a bit with survivors of domestic violence going through the family court system. And then we have Colleen Allen, who has worked many years in the area of addiction, works with women and families, and is going to talk about some of the major issues that we need to be mindful of when working with survivors of violence. And then, as I said, I will read an excerpt of a survivor of lived experience who unfortunately isn't able to share her story because she is worried about future retaliation from her partner. So with that, Carol, I will pass it over to you.
Thanks, Kendra. I'm really delighted to be here. I'm just going to share my screen. Anyway, I'm really delighted to be here with all of you and to be able to talk about this, the issue of substance use coercion. I'll also touch on mental health coercion and explain them and talk about how they impact survivors in multiple court settings with a focus on family courts. This is our center. We're the U.S. federally funded resource center, and it's U.S. Department of Health and Human Services Administration on Children, Youth, and Families, Family and Youth Services Bureau. With the Family Violence Prevention and Services Program funds all the DV programs in the United States, plus a whole cohort that's expanding network of national TA providers. And our center is the only one in the U.S. that's dedicated to addressing these intersecting issues of domestic violence, trauma, mental health, and substance use. We just didn't add it to the title because it's already too long. And we provide a comprehensive array of training and technical assistance, resources and support, research and evaluation. I'll share some of our research today, policy development and analysis and public awareness. And part of our work is trying to make sure that any of the research we do is going to be policy relevant and also support our training and technical assistance. And our mandate is to help the entire DV field in the US to do what we call accessible, culturally responsive, and trauma-informed services, and to support survivors who are experiencing the mental health and substance use and traumatic effects of domestic violence and other trauma across the lifespan, and also to influence other systems like the mental health and substance use disorder treatment system to do a better job of responding to intimate partner violence, but also the other systems that survivors interface with where mental health and substance use are often raised, particularly the child welfare, child protective services, and the legal system. So, and I wanted to do our land acknowledgement. We also recognize that Indigenous peoples are the longstanding inhabitants and caretakers of the land that we're on. Chicago is part of the traditional homelands of the Council of Three Fires, the Odawa, Ojibwe, and Potawatomi nations. Many other tribes, such as the Miami, Ho-Chunk, Sac, and Fox, also call this area home. Located at the intersection of several great waterways, the land naturally became a site of travel and healing for many tribes. Today, Chicago is still a place that calls people from diverse backgrounds to live and gather. Native American people continue to live in this region, and Chicago is home to the country's third largest urban Native American community, who still practice their heritage and traditions, including care for the land and the waterways. So now to shift gears, what I'm going to do is try to provide a framework for looking at the intersection of mental health, substance use, all these issues, how they impact survivors and their children, and how this comes up in court settings and other systems that people who abuse their partners actually leverage against survivors, which I'm sure you're all aware of. So this is just the first step of this framework. We know that intimate partner violence has significant mental health and substance use related effects. I'm going to show you data on each of these, but this is the overview part. And there are high rates of intimate partner violence and other trauma among people who are accessing mental health and substance use disorder treatment services. At the same time, people who abuse their partners actively use mental health and substance use related issues against their partners as a tactic of control. And that's what the focus of today's talk is going to be. But we also know that substance use, mental health also are major causes of custody loss and child removal, both in terms of child welfare, child protective services, but also in family court and custody. And that factoring mental health and substance use coercion into case dispositions is really critical, as well as offering integrated approaches to services and treatment that really factor in the coercive aspects is really critical to the safety and healing of survivors and their children. So here's a little more detail. So we know research has consistently documented that exposure to abuse is a significant factor in the development and exacerbation of psychiatric conditions and influences the course of recovery. Some are due to psychophysiological effects of trauma, some to self-medication for chronic pain, and deliberate undermining of a person's health, mental health, and well-being by abusive partners. So we look at the kinds of things where there's really increased rates, just for people who experience abuse by an intimate partner, PTSD, depression, suicidality. We know about chronic pain, insomnia, substance use, and opioid use. So we're looking at opioid use and opioid overdoses. Some of the risk factors for even using substances are self-medication for trauma-related conditions, for chronic pain, and for insomnia. So they're all often very much linked. Research on women who are living with or diagnosed with a psychiatric disability also show high rates of abuse. And for people who identify as LGBTQ, there are also higher rates of depression and substance use, and increased substance use, particularly associated with gender abuse of transgender women. When we originally made these slides, there wasn't as much research, but that's been rapidly expanding. But as you could see on the last slide, the rate of substance use is 6 times as high among people who experience intimate partner violence. So hold that in mind. This is the data around prevalence of intimate partner violence among people accessing mental health and substance use disorder treatment. And when you look at the substance use data, the 31 to 67% who reported domestic violence in the past year is really a proxy for people who are, at ongoing risk. And so one of the things in thinking about this in the context of family court and custody, there are many, many survivors who are accessing treatment in those systems who are not accessing DV services, and often are involved in divorces and custody cases without their providers understanding anything about how coercion is playing a role, how an abusive partner might leverage records, or they're actually accessing treatment, that kind of catch-22 against them in custody battles. So again, a lot of work on building those collaborations and kind of helping people who work in those systems to really use best practices in responding to IPV. So what's been less well recognized are the ways that people who abuse their partners engage in coercive tactics that are specifically targeted to their partner's mental health or use of substances, or their alleged mental health symptoms or use of substances, as part of a broader pattern of abuse and control. And it's the forms of abuse that are now come to be known as we sort of started this as mental health and substance use coercion. When we were first doing this work, we did a lit review, and substance use coercion only came up when people were coerced into substance use treatment by a punitive system. So we've sort of reclaimed that language. And basically what this is, abusive partners deliberately and actively doing things to undermine their partner's sanity and sobriety, controlling their access to treatment, then sabotaging their recovery efforts, and then using that against them to discredit them with potential sources of protection and support. And this came up particularly around custody. And I'm sure you see this all the time. And then another dimension is exploiting a partner's mental health or substance use for personal or financial gain. And that comes up often around being coerced into illegal activities. and human trafficking. So we know that survivors have been talking about these issues for years. I want to honor the work of Patty Bland, who was a fierce advocate who really started talking to women about their experiences, and really, before it was called substance use coercion, really described this. Qualitative research has also identified a lot of these tactics without calling it such. But the first large quantitative study on mental health and substance use coercion, we were fortunate to do in partnership with the National Domestic Violence Hotline. And this data is actually from 2012. The report was put out in 2014. And we're about to do a new study with them. So we're hoping to see some additional data, particularly around systems like court systems and other punitive systems. So the first study, the study was, the hotline at that time would do these focus surveys at the end of a call if someone wasn't in crisis, and it would be an interview, and it would be conducted over 6 weeks. Now they're so, the volume is so high that they only do online surveys. So this was the first call was over 2,700 women who agreed to participate because they really wanted to have their experiences help other people who might be going through similar kinds of things. So I want to really honor their generosity in participating in these surveys. So 86% of callers said that their partner or ex-partner had at some point called them crazy or accused them of being crazy as a way to undermine their self-esteem and their self-confidence. But 74% said that their partner had deliberately done things to make them feel like they were, quote unquote, going crazy or losing their mind, the act of gaslighting. So just think about that for a minute, how many people that is. Of the 53% had said they'd sought help at some point for feeling upset or depressed, some kind of counseling or mental health services. And of those, almost half said that their partner had tried to prevent or discourage them from getting that help or from taking prescribed medications. And 50% said that their partner, ex-partner, at some point had threatened to report that they were, quote unquote, crazy to keep them from getting something they wanted or needed. And often this was around custody, sometimes around a protective order. And some of the qualitative data, some of what we heard from people was, their partner would consistently try to diagnose them and read them diagnoses out of the DSM and tell them that they're sick, or try to interfere with treatment and convince their doctor or treatment provider that, that they were delusional, that they were crazy, that the abuse was a figment of their imagination. One person said that during a depressive episode, while she was highly medicated, her abusive partner maxed out her credit cards and threw her out of the house and then divorced her. Another person said that her partner prevented her from calling authorities many times because he told her she was crazy and no one would believe her. She tried calling the police several times and he manipulated the police and they didn't listen to her or protect her. She said, that's like hitting the nail on the head. Of all the things he was doing to me, he told me that if I tried to leave, he was going to take the kids and I would be in the psych ward. So we heard stories of people being forced to take an overdose and then being committed to a psychiatric unit for a suicide attempt, doing things like, with all the tech abuse, you can, control the heat and the locks on the doors and doing things like that, having the temperature go up and down, having loud noises, all kinds of things that people do to really undermine their partner's sense of their own, to be able to trust themselves and their sanity. Controlling medications, we heard a full range of withholding medications, forcing someone to take the wrong dose, forcing them to overdose, calling them an addict for taking medications, stealing their meds. So all of those things happen. And you can think of any way that someone could manipulate a person's mental health condition or medication against them. And then using mental health diagnoses to make false allegations and obtain a protective order. We'd heard people say, well, she was out of control and I had to restrain her, when we know that strangulation is one of the leading risk factors for DV-related homicide. The substance use coercion study that was over 3,000 callers, 26%. So these were not people in substance use treatment who said that they had any kind of issues with substance use. 26% said that had used substances at some point to reduce the pain of the abuse by their intimate partner. But 27% said they had been pressured or forced to use substances or use more than they wanted. So think about that as a route into substance use disorder and dependency. 50 of the 15% who tried to get help for their substance use, over 60% said that their partner had tried to prevent or discourage them from getting that help. 37.5% said their partner tried to threaten to report their substance use to an authority, again, to keep them from getting something they wanted, often a protective order or custody. And almost 25% said they were afraid to call the police because their partner convinced them that they either wouldn't be taken seriously, that they would have no credibility, or that they would be arrested if there were any kind of illegal substances or paraphernalia in the home. And that we know that survivors are often literally the ones who are left holding the bag. So when we look at some of the qualitative data, what we learned was, and this is from this study and from other work that we've been doing in the last 10 years, that survivors are often introduced to substances by an intimate partner who then ends up coercing them into using to the point where they become physiologically dependent, then controlling their supply, which ends up being a way to control them and keep them in the relationship. So people would talk about coercive tactics ranging from, being pressured into using and feeling like it wasn't safe to say no, or being forced to use, or literally being drugged. So there's a whole continuum of how that happens. So we've heard from a lot of people who've been coerced into human sex trafficking that is one of the ways that happens. The treatment interference was also very pronounced. People wouldn't be allowed to attend mutual aid meetings or seek treatment. Their partners would literally harass them into leaving, whether it was constant texting or phone calls. They would withhold transportation and childcare or any kind of financial resources. They would say they accuse them of having an affair with someone in their treatment program. And then they would either control their meds or steal their meds or use their meds against them, particularly if someone's on medication-assisted treatment, and escalate the violence if their partner actually tried to stop using. So one of the things that we think about often for anyone who's in the substance use disorder treatment field of the neurobiology of relapse cues, and when you think about that in the context of substance use coercion, can think about all those pathways that get triggered and all the things that actually can cue a relapse: exposure to addictive or rewarding drugs, condition cues from the environment, and exposure to stressful experiences. We know that some of this recovery sabotage is keeping drugs and alcohol in the home, pressuring someone to use. So there are lots of ways that can happen. So again, these neural pathways can be deliberately activated by an abusive partner. Again, blaming the abuse on a partner's substance use, it's because you're using, you deserve it, convincing people that they're worthless. And I'm sure we'll hear more about that later. Sexual substance use related coercion is often tied to sexual coercion. And so that's something that people talked about. We don't have a lot of data on that. And again, the threats to discredit and report, we heard stories of people forcing a partner to use, then videotaping them, and then calling their probation or parole officer or child protective services or their employers, or making false allegations. So just hold that in mind when you're thinking about all of the court contexts where this could come up. This is also particularly important in the context of the opioid epidemic. We know that intimate partner violence drastically increases the risk, for opioid use, and that there are high rates of intimate partner violence among people who are accessing opioid use disorder treatment. And that survivors of IPV are at much greater risk, 6 times higher risk for an opioid overdose. So again, they're very much intertwined. We know all of this has increased during COVID. So again, we're thinking about public policy and worrying and very concerned about the opioid epidemic, but not thinking about how much substance use coercion may be playing a role or contributing to opioid use and overdoses for survivors of IPV. So when we think about some of the specific forms this takes in the context of substance use coercion, again, introducing a partner and controlling their supply, and then threatening them with withdrawal, which is a very powerful tactic of control. And it's a way that abusive partners keep people in the relationship, but also coerce them into engaging in illegal activities. And once that happens, then survivors are at much greater risk, because once they're criminalized, then they are much more likely to lose custody and lose access to public benefits. Also, we hear lots of reports of forcing a provider to use unsafely and then ending up with all kinds of medical complications and endocarditis. If someone's having to keep very rigid appointments or medication-assisted treatment like methadone, and when their partner sabotages that, then they may be thrown out of treatment because they can't comply with the requirements, or it's easier to stalk someone if they're keeping regular appointments. So again, all of those kinds of things place survivors in much greater jeopardy, both in family court, in civil court, and in criminal contexts. I just want to highlight that the leading cause for opioid non-medically prescribed prescription pain reliever use is chronic pain. And we know that experiencing intimate partner violence increases your risk for chronic pain. The other piece to just kind of pull this part together is that we know that people who abuse their partners actively try to undermine a partner's relationship with their children, which creates risks for the kids. But we know research consistently documents that attachment to the non-abusive caregiver is what's really important for kids' attachment and development. Part of the policy implications are, we know that, I don't know how true this is in Canada, but in the United States, in 24 states plus Washington, D.C., using substances during pregnancy is considered child abuse and potentially grounds for removal, including for people who are using medication-assisted treatment for opioid use disorder, which is a standard of care of treatment. So there are lots of ways if someone is going to be drug tested that an abusive partner can force them to use, knowing they're going to get drug tested, and that puts them at risk for losing their kids. So just keeping that in mind in the family court context. We've talked to family court judges who say, well, if someone brings up substance use, then we're going to do drug testing when there's no reason to do that. And then call Child Protective Services or Child Welfare, because that's the only way we can develop wraparound services. But then that puts people in a system of surveillance that makes it very hard to retain custody because of the ways an abusive partner can sabotage their meeting those requirements. So this is just a kind of another visual way of thinking about all of this together, that the abuse itself increases the risk of a range of mental health and substance use conditions. Abusive partners then try to sabotage treatment and recovery, and then turn around and use it against their partners in court and other systems. And part of why they're so successful is because of the stigma associated with mental health and substance use that many judges also buy into. So what it does is it allows abusive partners to leverage stigma to manipulate punitive systems against their partners. So again, really critical for those of you working in family court, because this comes up all the time. And this is only further exacerbated by structural violence and who is more likely to be under surveillance, who's more likely to lose their kids. So let me just think, I'm just looking at time. So this is just to look at this in a bigger context. There's the traumatic effects of abuse and the ongoing coercive control and the traumatic legacies of historical trauma that are very much ongoing, and the kind of structural violence and public policies that perpetuate abuse, violence, and discrimination, and that many of the systems we work in are part of that kind of system. So as advocates, part of our role is to try to transform those policies. So how does this play out in family court? Well, in the court system? First of all, as I mentioned, substance use is a major cause of child removal in the United States. And when we think about custody and permanency in family court and dependency court, from our surveys, the people who partners threaten to report them to authorities, most of them, 72% of those partners prevented them from or discouraged them from getting mental health treatment, and 94% of the callers whose partners had prevented them from getting substance use disorder treatment were among those who threatened to report them to authorities or did. So just thinking about that, it's the same people. So red flags, things to consider. Is mental health and substance use a genuine concern? Is the party raising the issues really concerned, or are they doing things to exacerbate that condition or interfere with treatment? If someone has a supportive partner, they're not going to use it against them in court, even if they're getting a divorce. And that the party raising the issue, have they indicated any concern about the children's safety prior to the litigation? So there's lots of things to think about in that context. We also know that substance use is a major factor in women's incarceration, particularly in low-level drug crimes. And that's also a reason why someone might lose custody of their kids if they're incarcerated or if they have a criminal record for substance use. So again, thinking about all of these issues that come up in criminal context, but may play out in family court. Survivors also talked about being literally left holding the bag when the police come, or being convinced that they'll get a lesser sentence, so they should be the ones who takes the rap. But one of the things that's come up, particularly around drug treatment court, is that court-mandated treatment providers aren't trained on how to provide safe treatment for survivors of intimate partner violence. They're very sobriety oriented and not harm reduction. Don't take a harm reduction approach. They have random drug testing and very rigid treatment requirements that someone who's experiencing substance use coercion is not going to be able to comply with. And that further increases their risk for loss of custody. We also know that mental health and substance use related stigma impacts survivors' credibility. We know that they may not be able to get a protective order because their partner's claiming that they're the one who's out of control, or they may not have their criminal case taken up because prosecutors won't bring the case. They don't think it's winnable if substance use is part of the picture for the survivor. So what are some things we can do? And I'm just looking at time. I think I have about 5 more minutes. So one is we have a toolkit on responding to mental health and substance use coercion in primary care and behavioral health settings, but a lot of the information in there is also relevant for family court. Considering the role this may be playing, recognizing red flags. If an abusive partner is raising this as an issue, think about that there may be coercion involved. Incorporate questions about mental health and substance use coercion if this has already been raised. One of the big concerns is that if an abusive partner hasn't raised it or there aren't any allegations, then bringing it up may jeopardize a survivor's ability to maintain custody of their children. So again, being judicious in how you think about this, and thinking about the risks to recovery, and if those are conditions for custody or retaining custody, to think about what may be getting in the way and what needs to be in place to make that safe. So this is just I'm going to kind of just touch on my next slide so I don't take up more time, but thinking about the kinds of things that you may be seeing if someone is, like trying to access treatment and won't be able to, or not able to call the police. And then what are some of the things that may be happening that an abusive partner is actually engaging in to create those issues, manipulating your perceptions, treatment sabotage, coerced use, illegal activities, all those kinds of things. Incorporating some of this into your assessments. And these are questions from the toolkit. If this comes up in a way that you can use it in a way that doesn't place survivors in jeopardy. And these will be in the handouts, so I'm not going to read through them right now. Thinking about substance use, there's so much stigma around substance use, and assuming that implies that people aren't good parents when it doesn't. So many people use substances, never come before the courts, and are perfectly good parents. So again, really factoring that in, are kids really in danger? Can there be safety planning around safe substance use and making sure the kids are safe, and making sure that people have access to treatment that's actually responsive to domestic violence. So again, how to factor this into decision-making and treatment plans, and making sure that the abusive party doesn't control the discourse or perceptions about a partner's mental health or substance use. This is from the American College of OBGYN, and it's really saying that you should not be doing random drug testing for people who are pregnant without informed consent, because a lot of states in the US don't require testing, but people do it anyway, and then it ends up putting people in lots of jeopardy, both with child welfare and in terms of custody. One of the things to think about if you're making referrals for treatment, there are lots of barriers. There are a lot of philosophical barriers in substance use treatment in terms of a non-empowerment based approach, people taking responsibility for the use of substances in ways that doesn't factor in coercion, making sure that services are safe, if they're mixed gender, that there aren't abusive partner isn't there too, or other predators, being more flexible in treatment times, and working with survivors on how to safely access treatment, and factoring substance use coercion into relapse prevention. So again, transportation, childcare, lots of things in the harm reduction approach. So if that comes up in any of the court contexts, to be thinking about that. And this is in the toolkit as well, just really thinking through how to safety planning that includes accessing treatment, safe access to medication, safety around electronic health records, and documenting in ways that would be useful to someone in a custody case as opposed to detrimental. Having a comprehensive array of services, which we know aren't available, possibly some coordination between DV, family, and drug courts in ways that help people access resources and help to train people in drug courts about some of these issues. And then I'm going to stop here. Here are some questions for when we get to the question part. How is this coming up? How would you think about how to factor the mental health and substance use and coercion into your cases in ways that don't place survivors in jeopardy and actually help them with their cases? How could you factor this into strategies for responding to the impact of parental substance use on children? So what kinds of partnerships and resources do you need? So I'm going to stop here. We're going to do questions at the end. This is our POM card on substance use coercion, the toolkit, things that substance use disorder treatment programs need to be aware of ways that things they do that could be harmful to survivors of IPV, and then some of our other resources and the disclaimer from our funder. So I'm going to stop here and stop sharing.
Wonderful. Thank you, Carol. That was just absolutely terrific. I know I've had requests about your slides. We are going to post them on the Resolve website probably tomorrow. But Carol, I just want to say what a fascinating presentation. I think you laid the groundwork in terms of getting us to understand what substance use coercion is. I think we are aware of these tactics, but I don't think anybody's ever kind of, or rarely, like you said, have framed it in a way. And then, considering how we perceive, survivors' behavior and choices, and how that, or quote unquote choices, and how we flip that to how that's, how the perpetrator has, contributed to that behavior, I think was excellent. And of course, the considerations for family court. So thank you. I think that's an excellent segue into what Brina is going to be talking about and what you've seen, I guess, Brina, in family court related to substance use coercion, or, the larger maybe mental health coercion. So I'm going to pass it over to you, and you have about 13 or 14 minutes.
Thank you, Kendra. So first, I just want to start out with acknowledging that my offices do sit on Treaty 2 territories, and that we do respect and appreciate all of our Indigenous, sorry, I am stumbling over my words. So we acknowledge with respect and gratitude that our offices sit on Treaty 2 lands, which are the traditional homelands of Dakota Cree, Oji Cree, and Anishinaabe, Ek, as well as Dene peoples. Just to give you guys a brief background on myself, I got my call to the bar and have been practicing in Brandon since 2011 with Patterson's LLP, or the previous firms as it has been. My primary areas of practice have been family law and child protection law since that time. Currently, I am the agency lawyer for 2 Indigenous agencies in the West Van area, the first being Dakota Ojibwe Child and Family Services, as well as Dakota Tawahi Services, which is a new child protection service that just got their mandate last July for our Sioux Valley First Nation just west of Brandon here. So just to talk briefly, I'm going to break this down into two separate situations. The first is what I consider the family law, and that's custody, where one parent is fighting with another parent over custody. The second situation is that child protection situation where we have a CFS agency getting involved in the family. So with family law, it's been my experience that judges rarely will take into consideration any substance use by either partner unless CFS has gotten involved somehow in the family. I think a lot of the time our judges don't want to get into the area because they see a lot of allegations being thrown back and forth between parents, and it seems cleaner just to leave it out altogether. That said, in March of 2021, the changes to the Divorce Act came in, and one of the major changes with that is that it does include having to take into consideration family violence when determining custody situations. So it will be interesting to see how this plays out and how substance abuse coercion might start to come into play as well in the family court because of these changes. Particularly 16(4)(b) of the Divorce Act does state that judges should take into consideration whether there has been a pattern of coercive or controlling behavior in relation to a family member. So certainly if there was any allegations of substance abuse against a victim of family violence, we as family lawyers need to start looking at whether this is substance abuse coercion by the abuser and taking into consideration all of these factors as well. We're only just now beginning to see impacts of these changes in Manitoba. In particularly, I think there's only one reported decision that just came out in December of this past year that deals specifically with taking into consideration the family violence factors when determining custody for a situation. As a family law lawyer, it's something that I have always struggled with when we start discussing family violence, particularly when we're talking about emotional abuse or psychological abuse for a victim, because it's so difficult not only to prove that you have been psychologically or emotionally abused, but it's so difficult to actually explain it because a lot of the time the factors that we're looking at are so minute when you look at them in a very situational circumstance, and you're not looking at the overall picture of the relationship. In addition to that, we also have to consider the trauma that our clients are going to experience if we do take into consideration going to court and trying to prove that there has in fact been family violence when we're dealing with custody. Because at the end of the day, the judges have to look at the principle of the child spending the most time with each parent that's consistent with the best interests of that child. And so not only are you making the argument that there has in fact been abuse, but you also have to then make the argument that this abuse is not, therefore it's not in the best interest of the child to be with that other parent. And when we're talking about things like psychological abuse, it's so difficult to be able to explain that. And I think there needs to be a lot more resources and research for family law lawyers to actually rely on so that we can make better arguments for our clients. So moving on to the second topic of child protection. So this is where a child and family services agency is getting involved with a family as a result of having protection concerns for the children. And in my experience, looking back now after I've heard about substance abuse coercion, it's certainly something that has come up on files, but it's definitely not anything that we've ever named as such. And so it's going to be quite interesting to look at files going forward with that new lens of realizing what exactly is going on with some of the women in particular and the victims of abuse that we're dealing with when it comes to child protection cases. I think a very typical response that we have with agencies is that they will get involved with a family because of an abuser's behavior, whether that's the abuse that he is inflicting on the victim or whether it's his substance abuse that has become a concern, and they will try to remove him from the home. And whether or not they're successful at keeping the children in the home initially, or whether they have to apprehend initially and then return after the victim is able to terminate the relationship, we often see that abuser coming back into the home. And whether they're invited or not, it starts that cycle of substance abuse coercion where the woman will start using, whether it's alcohol or other substances. The police end up getting called by somebody, or the agency ends up getting called by somebody, and then the children are taken back into care because they're determined to no longer be safe in the situation. Alternatively, we've seen abusive partners make allegations against victims about their substance abuse, and the agency has a requirement that they have to investigate these. And so unfortunately, drug tests will come up positive, and if there's no reasonable safety plan that can be put into place, yet again, we're apprehending children and taking them into care. We've also seen abusers actively sabotaging victims' attempts at recovery, whether by keeping alcohol in the home despite her trying to become sober, or bringing drugs into the home, just being in the home himself. We see that quite often as well. And I think it becomes frustrating for agency workers in particular because they don't have the resources to be able to help the women with both issues at the same time, which is really what's needed here. We need to address the issue of the abuse as well as the substance use by the victim in order to address the real issues. Because if we're only addressing one at a time, we leave the woman in a very difficult position where they're still struggling with the other issue and they don't have the help that they need. It's also quite frequent, unfortunately, that moms will not share their substance addiction issues with the agency because of the fear of their children being apprehended as a result. And I do work with two really great agencies who are trying to implement in safety planning that, will take into consideration whether or not substance use is actually putting the children at harm. But there's a long history with any CFS agency where, rightfully so, people are scared that if they come to them, they will have their children taken away, which also prevents the agency from them then helping at a time when we could probably keep the children in their care. I think with respect to child protection agencies, one of our largest concerns and issues at hand is the fact that there are no integrated services in Manitoba. to deal with both domestic violence and substance abuse at the same time. I think that we also have a significant issue where any of our treatment centers in Manitoba, save for, I believe, 2, don't have a detox center attached to them, which creates a very difficult situation where you're trying to line up a detox bed at one center to have the person completely detoxed in time for them to transfer to a treatment center with no in between where they can relapse and then have to do detox again. And throughout all of this, CFS is, of course, under the obligation to ensure that the children remain safe. So they are often apprehending children and placing them hopefully with family members, but oftentimes with foster parents, which then, of course, creates a setback and trauma for the women and the victims that we're working with. The one huge recommendation that I would have outside of just a general education of everybody involved with any sort of family court system is that we do really need to look at our triage system in Manitoba for family court. We had a major change to it back in 2018, and the intent was to try to make things go quicker and not delay court cases. But unfortunately, what has happened is that we're no longer able to get interim child support or interim custody orders for our clients without also dealing with property and any other outstanding issues that might be there. So this leaves a lot of women in particular in situations where they can't afford to go to court because they can't afford to keep paying all the bills that they've been left with, keep paying all the childcare bills that they have, and pay for their lawyer. They are victimized again by their abusers because the abusers will withhold payments, they'll withhold payments on the house, on the rent, on the mortgage, and it forces women to make unfair decisions about their settlements so that they can just survive. We also see that with that lack of custody orders, that children are often used as pawns in a game with abusers, where they won't agree to regular schedules for the kids or reasonable schedules. They'll withhold the children when they're angry at the mother for whatever reason, and there's very little that we can do about it. So I think that for me is our biggest hurdle from a family lawyer perspective, and something that definitely needs to be looked at.
Wonderful. Thanks, Brina. Thank you for sharing what you see in the family court regarding substance use coercion. As you said, it hasn't really been looked at through that lens. You know, and you've connected a lot of these issues with structural issues too, right? Having to, you know, women have to support themselves and their children, yet navigate an expensive family court process. So all of this compounds with issues of mental health and substance use. So thank you for that. And you also talked about kind of the lack of treatment options for intimate partner violence and substance use. So on that note, I'm going to hand it over to Colleen to talk about the major issues she's seeing regarding intimate partner violence and substance use. Colleen?
Hi. I really just, I'm just awed at all of the issues that women do face, and I'm just going to add to them and really beginning to look at how do people recover, what is needed, and what is just the effect of the addiction on their ability to make use and motivate them for treatment. So one of the areas I'm going to do at the moment is just really go over some of the areas that we have been really, I guess, not knowledgeable about. And that is just alcohol alone effect on women particularly. And some of you will have known that for years, we in the field know exactly how toxic alcohol can be. And this past year, finally, it just has been identified, although we knew this, is that alcohol is a toxic substance and has been identified now as the #1 preventative carcinogen, along with asbestos and nicotine by the CCSA, which is the Canadian Centre on Substance Abuse. And they acknowledge that substance abuse is an important consideration for all women, and that women's health includes all women, not just cisgender, and have revised their recommendations of safe levels of alcohol use to 1 to 2 drinks a week for both men and women. Before that, it was looking at 10 drinks a week for women and 12 for men. So you can see just how much they have looked at the research and what has now said, hey, look, this is what's happening. And women are particularly susceptible to alcohol-related harms because of both sex, biological, and gender, and social factors, which still judge alcohol and drug abuse in women more harshly than in men. Warnings, and we've known now, we've been hearing about this, but not all women know of the alcohol's correlation to breast cancer, and has been known, I've known it since 1987. And women who have a history of breast cancer in the family should really limit their drinking. And also for those that have had breast cancer, should not be using at all. And I'm going to just illustrate some of the results that we have had in terms of what we now know are some of the effects. Because this affects the women who come to us, both because we know that alcohol and violence, interpersonal violence, is really highly correlated. So some of the things that make women more vulnerable is the fact that alcohol is distributed through the body water to every cell of our body and collects in organs with higher concentrations of water, such as the brain, liver, heart, colon, pancreas, kidneys, resulting in these organs being more vulnerable to damage. For many years, women's death due to alcohol abuse resulting in cirrhosis of the liver was only identified on autopsy. And we now know that there are biological and metabolic factors. Women have on average 25% less body water. Women have less enzymes in their stomach and liver to metabolize alcohol. 30% of the alcohol drank actually goes right from the stomach directly into the bloodstream without being diluted going through the liver. It goes straight through. So what you have is alcohol that is undiluted and in higher concentrations going through the body. Alcohol's correlation, yes, breast cancer is becoming more known, but the correlation to high blood pressure, strokes, and heart disease is not. In fact, cirrhosis of the liver is now becoming a silent epidemic among young women. I have 2 past participants of ours. One, 26 years old, needed a liver transplant, and she's received it because she was able to stay clean and sober. Alcohol alone, never realizing, never guessing that this was going to result in the damage that she has to look at preserving that liver for the rest of her life. Another young lady was also looking at alcohol abuse. No one thought she would, her parents or friends never seemed to, she was successful. How could she have an alcohol problem? She ended up in a coma in hospital. alcohol alone, not able to walk, not able to talk, losing her home, losing her career, and actually for 6 months lived not knowing whether she would survive or not in terms of the damage to her liver. The highest incidence of children born with FASD are those women 18 to 25 and from 35 to 45. And it seems that what happens is the young women are, particularly in university, and binge drinking a lot. And from the women, 35 to 45 have put off their childbearing years. And so now have a pattern of use, which may not seem abusive. But again, when you're looking at FASD, when you're looking at harms, every extra drink does cause problems. And we've never really recognized the extent of that. Women's brains are more profoundly impacted, particularly their short-term memory function, which can last 2 to 5 years into recovery. And one of the things we've really found, it mimics almost a stroke or concussion. And the damage is quite profound for some women. And they really, I know one young lady just thanked me for sharing and said, I thought I was losing my mind because they can't remember. And they can read, they may go into treatment and 21 to 28 days, but that just stabilizes them. And when you ask, what have you learned? What have you learned to be able to stay clean and sober? The tools that were given to them are gone in terms of their memory. The impact on alcohol use has always been highly correlated, and many forms of the abuse for the women that are coming into our center. And I'll just state that our center is not a treatment center. It is for people who are trying to access treatment or who are mandated but don't think they have a problem. We also look at continuing recovery. Again, as I mentioned, 21 to 28 days does not a sober person make. And people have to say, well, now, how do I live? Women who present for intakes have experienced or witnessed physical and sexual violence and have a myriad of other diagnosed and non-diagnosed mental health and physical issues. I'm not going to go into all of the things that happen in terms of violence with partners, but we do know from all of the 2 previous speakers that it's been well represented. I'm going to look at the actual presentations of people who are coming to us in our center, and 70% are Indigenous. The majority present with co-occurring disorders such as anxiety, depression, and bipolar, as well as physical issues such as autoimmune diseases, reproductive issues, upper respiratory issues such as colds, bronchitis, pneumonia, gastrointestinal, and flus. During COVID, they were very susceptible, and still today, some of our participants have had COVID 3 to 4 times. FASD effects are often undiagnosed but suspected by counselors from presenting cognitive and behavioral impairments. Most of our participants have healthcare workers, psychiatrists, probation officers, CFS workers, and unfortunately, each has a different take on what they need for recovery, and there is little system integration. I think this was mentioned, which is a very important issue as they're trying to recover. And you've mentioned financially dependent on their abuser. And even though there may be a no contact order, she will often take them back from just being worn down. And As mentioned before, women speak about being goaded into responding with violence, so the abuse is justified. They are not formally diagnosed with many symptoms of post-traumatic stress disorder, but they also present, as mentioned before, on intake with suicidal ideation and indicate anywhere from 2 to 3 suicide attempts. And I'm just going to move on here because some of this has been covered. During COVID, SRWC, as with other addictions, lost participants to overdoses, suicide, and relapse. Isolating with small children and abusive partner was an issue for being able to receive support by telephone and Zoom. We had calls, they were reporting mutual abuse, lack of response, and of course the police were just really overwhelmed, and all of the calls were going for naught. We had to actually go through a young woman calling us. She was on the street in the middle of the night because she had nowhere to go, and there was no help to come. Also, she may not recognize the danger of fighting back, nor recognize injuries sustained until she sobers up. Women hesitate to leave, as mentioned, or accept help if she has children and cannot take them with her, as she is often isolated by the abuser. If she has no one to care for her children, they are often taken into custody. If she has an alcohol or drug problem, she needs to comply with CFS and probation before she has supervised visits or she regains custody. And as mentioned, if she enters a treatment facility, this can be used against her in a custody suit. Sometimes she has no choice except to separate if she wishes to retain custody of her children. But again, making her vulnerable to increased violence and sadly risking her and her children's lives. If she's pregnant, she's especially vulnerable to abuse. And there has been situations where there's children in care, and there is at times coercion to put the child up for adoption, or in some cases to have her tubes tied. And there are so many barriers to recovery, which is what I do want to focus on, because we do need to look at the systems that surround women who are experiencing violence and substance abuse, and we need to be on the same page as we're working with them. The issue is, and I think this was really well illustrated, she will face financial difficulty raising children, finding available childcare, not receiving regular, or in most cases, not receiving financial help. Maintenance orders are often sporadic or non-existent. The partners with financial means often quit jobs or hide their actual income to avoid paying maintenance. And if CFS or probation are involved, or the justice system, she is usually on EIA or other assistance. If she enters a residential treatment facility, there is no assistance if they are on EIA for continued support. EIA does not support our program, for instance, community-based programs, only residential, even though they are mandated to attend or forfeit their EIA checks. They may not receive, we have to lobby for transportation or supports if they are singers, safe housing, or children in care. Even if they have children at home, there is no respite to attend programs. They need to pay fees out of their meager allowances for help. We try to help with transportation, but most of our smaller agencies are underfunded. And if sometimes they refuse them, if they have been attending ongoing recovery for 3 months, there's an attitude, well, aren't they cured yet? Why do they still have to keep coming? If she's successful in meeting all the criteria for her to have her children returned to her, she is not supported with respite to continue. If she has born children with and identified with suspected FASD, there are still birth alerts and coercion to either give up the child for adoption and or have her tubes tied. There are few resources for ongoing recovery for women that are both accessible and timely. If she is with her partner, as mentioned, they are suspicious and jealous of her receiving help. Who is she talking to? What did she say to whom? Stalking her. There have been scream fests inside our center with the partner waiting outside while she is en route and stalking up and saying, like, why is she 5 minutes late? Women who do not have a addiction problem, but if their partner has, they are often in worse shape, as all of the things that Carol illustrated. Suffering stress-related illness such as sleeplessness, eating disorders, suicidal ideation, high blood pressure, feeling guilty that they are somehow to blame for the abuse and violence. We have had last year 2 affected women by their partner's abuse pass away from heart attacks after being warned by their physician that their blood pressure was so high that they were in danger of a heart attack. On the night of one's operation that she did not survive, her partner managed to get through to her hospital room from jail, and her last experience on earth was in vindictive threats if he did not let her see her son, his son. Women are often reluctant if there is a partner in a high-profile job, as there is the taunts. No one would believe her, and she is afraid of the consequences, not the least financial to her children, if he loses his job or is demoted. Lawyers, judges, physicians, political, armed forces, police, RCMP, pastors, just to name a few. If she leaves, she needs to make a decision, in most cases, to be poor and sacrifice her children's future and education. They often stay for the sake of the children, and if they do try to divorce, separate, or end the relationship, her and her children are often in danger and sometimes pay with their lives. No contact orders are often even ignored, even with being charged with multiple offenses. There are some women in our programs right now that are living in terror of their abusers being let out on bail or receiving really minimal sentences. All who are involved in the justice system should be educated on the relationship of interpersonal violence, the subtle and direct coercion that women face under family law regarding support, custody of the children, which were all illustrated. And I do want to say that we work with some wonderful people, but there is a lack of understanding of what women do face as they try to remain sober, invest in their recovery, and still be able to survive financially with their children and receive the help that they need. Many women self-medicate to deal with the physical and psychological pain they are experiencing. Unfortunately, many are given benzodiazepines, which they are not allowed to be on while they enter residential treatment. And they do not realize that even though they follow a prescription faithfully, unfortunately, they don't realize that they can still become addicted. And the medication immobilizes them and renders them vulnerable to further abuse. It is also important that all involved are, again, informed of the dynamics and the impact of the substance abuse on one or both partners. Education is key to understanding and compassion. Just imagine what it takes to change your whole life. As with other health issues, there is movement ahead and back. Relapse is expected, but not inevitable. And it seems that as people realize what is needed for recovery, Many healthcare workers do not understand. Social workers don't understand. Many do, but many do not. Just what it takes to be able to stay sober once and forever. It's a going forward and 2 steps back. And you have to, and it takes time. And they need support while they do it. And relapse is expected, but not inevitable. Healthcare providers should be made aware that substantial healing takes time, and the supports that are needed to encourage those experiencing substance abuse and violence, and the challenges it takes to overcome an addiction, and the courage that it takes to be able to sever relationships and their dreams in terms of this person that they thought that was they were going to spend their life with. I cannot speak more highly of some of the workers that are in the field who just really go to the wall for some of their clients. But on the other hand, there is so many gaps in the system that we have help, but it is not integrated. And so we sometimes are working against each other in terms of trying to look at what is best and what is viable for our clientele.
Colleen,
Sometimes also there is a lack of understanding because now that marijuana, for instance, is now legal to use, I have heard that some of their workers are saying it's legal, that's okay, it's legal now. But the issue is that they still are not looking at the effect of cannabis on themselves, and that they are also able to be cross-addicted to marijuana. And the other is the effect on the children. So I don't want to go into all of that. That's a whole other issue.
Yeah.
But
Yes.
now that it's become legal, I think that is another area of research. Thank you.
Thank you, Colleen, so much. And I'm sorry to interrupt. I could listen to you talk for a
Oh,
long
that's
time.
fine.
I'm
I'm speed talking, so that's fine.
It was wonderful. You did an excellent job presenting, the myriad of struggles and, barriers and issues that women experience who have substance use concerns. So I just want to turn it over now to hear the story of someone with lived experience. So as I said, this project is part of our Community of Practice Family Law and Family Violence project. And part of our group of experts includes those with lived experience. And so our philosophy behind the entire project is that we need to hear the voices of survivors and those who have, as I said, lived experience. But unfortunately, many aren't able to do that because they fear retaliation, fear of how, what they say could be used against them in maybe future court proceedings. So I did want to read a story that someone sent me, and I as a way to kind of end the presentation and kind of a segue into questions. So we probably have about 5 minutes for questions if you want to think about some questions for our panelists and type them in the Q&A tab. So this person has written, in a perfect world, I would be here introducing myself, showing my face and sharing my story. What I am able to share is that I'm a white female who has the privilege of being knowledgeable with a career in the social services system. I have the privilege of owning a vehicle, cell phone, having a strong support network around me, formal and informal, and living in a city where I speak the same language. What I have learned is that domestic violence and coercive control does not choose what social status or privileges you have. As a person who have never experienced anxiety or depression, but works in a field where mental health is spoken about daily, my own lived experience opened my eyes in so many ways. You truly have no idea what it is like to struggle every single day, feeling like your power has been taken from you, to be told you are crazy, to have a system that has so many gaps in supporting survivors, to share your story over and over again to police, but to be told nothing can be done. Having to wait until Monday morning to try to get a hold of a professional support that you rely on, even though you are experiencing a major crisis 24/7. To feel so helpless, balance working, parenting, all while trying to navigate this life-changing experience. To feel like you are aware of what you would direct your clients to do after a domestic violence situation, but then experiencing psychological and physical abuse and realizing that sometimes the failure in the system can add to the trauma of everything else. And to be silenced after everything you have healed from, because it is still unsafe to share my story, my voice. I am not proud of my response to my ex-partner's abuse that led me down a spiral of increasing my alcohol, marijuana, and nicotine intake. I often reflect on how I wish I didn't use that to cope with the pain I was experiencing and put myself down on not being emotionally available to my child at that time. Added shame along to the shaming I was receiving from my ex-husband, and now he used my responses to his abuse, and how he has used my responses to his abuse against me as a human and as a mom. Now I know I cannot be hard on myself because the pain endured was something I wish no one to experience. And I'm damn proud of making it on the other side. And although not able to share my story publicly, I find myself helping other women who are experiencing coercive control and domestic violence. I have realized I have strength I never knew I had inside me. I have learned that within my professional practice, I can relate and empathize even more. Now knowing what one has to do to navigate the system that will most likely fail her, balance work and parenting along with every other responsibility that is on your shoulders at that time. The system could learn from us who have lived experience, but at the end of the day, our voices will remain silenced because of the dangers of retaliation from our offenders of what could happen if we share our stories. Coercive control is no joke. I am incredibly upset that I cannot sit here today and share who I am and what I've been through. I am angry that I've wasted thousands of dollars to essentially get me nowhere. I am sad that I had to lose a period of my life emotionally that could have been spent on my daughter. And I'm pissed that this could be something that could be credited for my career. She's speaking about being part of the presentation. But because I have to be kept anonymous, it's something I won't gain professionally. People may think domestic violence is limited to either physical abuse or bullying, but abuse is about gaining and keeping power. And because I am silenced from sharing my story today, this is something that continues to abuse my life every single day. So I just wanted to kind of end with that. Patricia, if you could go back to put on the PowerPoint presentation, please. So again, I want to thank our presenters, our panelists. We do have some time for maybe a couple of questions and answers. I know people have asked us to make the slides available. We will do that through the Resolve website. People can email me directly. I'm sure we have our email address at the end, so certainly you can connect with us that way. I know there were many who expressed, Brina, some of the challenges you mentioned about the triaged family court system. So it seems like that is not only something that you've experienced, but others as well. So I don't know, Brina, if you want to maybe say a couple sentences about the triage system more than that was in your presentation.
Yeah, so I think it is definitely something that needs to be looked at. And I think having it brought from the perspective of people working with those experiencing domestic violence is very important as well, because it's frustrating for lawyers to not be able to help their clients, but more so it's the endured trauma that our clients experience as a result of a system that was created to help them, but actually ends up failing them significantly. We need to be able to get child support and custody on an interim basis going as quickly as possible for people leaving any relationship, but most significantly for those leaving domestic violence situations, because there are so many barriers that women in particular have of leaving a relationship. When we add on the fact that they don't have access to support for their children through something that they are entitled to by law, it just adds to their fear of leaving.
Yeah. Thanks, Brina. Oh, I'm trying to look at the questions. Oh, we do have questions about the survey. So that's what we kind of do at the very end of the webinar, is we'd like people's feedback. So the survey is in the chat, or there's also the survey here on the form. Patricia, our communications specialist, will also send out an email afterwards with the survey link. I'm just, I think I'm just trying to look at the questions. I guess, maybe I'll just leave maybe the last question to Carol. Carol, this is something you've been looking at for a while, and I know from having other conversations with you, you've trained judges, you've worked with judges, you've worked in the family court system or professionals in that system. What advice would you, or what do you think is really needed? As Brina was saying, and what I've noted to you is that I think that, we all kind of can identify some of these tactics, but we haven't really considered it as this full lens that you talk about, right? And we haven't reinterpreted really women's responses, right? We see it as, okay, we look at them in a kind of a deficit model, right? That how they're pathologized and how they're using substances, right? We're not kind of looking at it from a substance use coercion, that this is another tactic. So, I mean, in a couple of sentences, I know we don't have much more time, but what do you think we should know in terms of going forward in terms of family law? I know you had given a lot of great questions or things to look for, red flags, but
I think one of the things we're trying to do, and working partly with the Center for Court Innovation, and that's based in New York, is trying to, and we did some work with the Battered Women's Justice Project, also trying to engage court systems, judges, and lawyers, and working those systems to think about new strategies that they could, given the constraints under which they operate. So the biggest one is around education and stigma, because people, that's part of why these tactics work, is because they they can leverage the stigma that everyone, something wrong with her. Or judges will say, well, I have a couple sitting in front of me and she looks like she's a mess and he looks like he's really well put together, the person who's been creating the problem in the first place, who do I give the kids to? And so if you raise that if that's an issue, he's bringing that up, or she, depending on who it is, to be able to factor that in and figure out what is the person who's being, experiencing the mental health and substance use coercion need, how much is that around safety? How much is it support? All the things that everyone's talked about. And then what levers do family courts have as opposed to dependency courts? One of the struggles in the US is in dependency court, you can, require people to engage in all kinds of wraparound services that might actually support them and being able to keep their kids. And in family court, people don't have that, but doesn't mean they couldn't figure out some strategies, but people need to start to figure out what's doable. But then the problem is if the services don't exist that would actually be supportive, and there are all of the constraints that everyone talked about finances, rigid requirement, all the things. So it means having people who have lived experience, helping to shape what would be helpful, what needs to be in place, how do systems work together, and how do we develop strategies that aren't going to backfire. So
thanks, Carol. Well, I'm really hoping that we can take a lot of what we've learned today and use it in our community of practice, right? To, provide greater awareness and resources to those practicing family law, and also those who are working with survivors, whether that could be through shelters, but even through substance use programs. So I guess I'm looking at the time. It's time that we're ending our webinar. If you could forward to the next slide. So there is a survey. We'll be sending it out. We've put the link to the survey in the chat if you can fill that out. Again, just to acknowledge that this is an Alliance of Canadian Research Center project. For more information about the project, please visit our website. We record all of our webinars. We probably have about 12 of them that we've had so far. We translate them into French. We also produce both French and English written reports based on the webinar with lots of resources. So I encourage you to access the Alliance website if you want more information about what other webinars we've hosted regarding family law and family violence. And of course, if you have more questions about the project, about any of this, my email's here. Please feel free to reach out to me anytime. Next slide. For those of you who are Manitoba social workers, you can get professional credit for attending. We have details for that. Next slide, please. And of course, you know, again, I just want to say thank you to everyone for attending. For today's webinar, I want to thank all the organizers, but of course, I also want to thank the panelists, as well as the our survivor with lived experience, to be able to share her words that way. That's really important. So please stay connected with Resolve. We have a number of ways to do that through social media and email. So with that, I'm going to say goodbye to everyone. I'm just hoping that the panelists and others like Patricia and Ashley could maybe stay on, and we'll just have the registrants leave now. Again, thank you so much, everyone.